to me directly. At this time, I would like to turn today's program over to Canada Health Infoway. The floor is yours.
Good morning to those of you joining us in the West, and good morning and good afternoon to those of you in the East. My name is Karen Taylor-Hughes, and I'll be a moderator today for this Change Management webinar. Notice of recording. This session will be recorded and may be posted on Infoway's website, used for future internal or external education sessions. Please use the Q&A feature if you wish to ask a question. The moderator, which is myself, will pose a question on your behalf. Your name will not be used. We have a disclaimer just letting you know the views that will be discussed today will be that up top towards optimized practice and not those of Infoway. This is intended to be an informative webinar only and cannot be interpreted as providing any indication of Infoway's present or future strategies or investment criteria. And we do not endorse any particular technology or solution of any vendor or any other person. Therefore, it does not guarantee the reliability or any results related to use of such technology or solution, and this notwithstanding that reference may be made directly or indirectly to any such technology or solution in this webinar. Again, I'm Karen Taylor-Hughes, the moderator. I'm very happy to present to you our presenters for the day, Doug Steek, Barbara McCaffrey, and Margot Schmitt-Boshnick. I'll tell you a little bit about Doug. Doug Steek is the Program Director of Towards Optimized Practice, otherwise referred to as a program that works with Alberta physicians and their teams to implement evidence-based clinical improvements to enhance the care of their patients. Doug is responsible for TOP's strategic program development, strategic partnership management, stakeholder relations, and evaluation of outcomes. TOP works with community-based physicians and their teams to facilitate the implementation of clinical practice improvements using evidence-based, specific, and measurable best practices and innovations. TOP helps teams in primary and specialty care practices and also primary care organizations. And there are some examples of the primary care networks, family care clinics, and community health centers. TOP also develops clinical practice guidelines. Doug has had a long career in healthcare with a special focus on clinical and process behavior change. Prior to joining TOP in 2004, Doug was Program Coordinator for the Pharmaceutical Information Network at Alberta WellNet and has served as the Director of Change Management for Manitoba's Smart Health Initiative. Doug has a Bachelor of Science degree from the University of Manitoba. Along with Doug is Barbara McCaffrey, who is an EMR Knowledge Transfer Lead for Towards Optimized Practice, and she is also a member of our Pan-Canadian Change Management Network and a member of our Change Management Ref Group. Margot Schmitt-Boshnick, the Master in Education and Evaluation Specialist at Towards Optimized Practice. I'm very happy to welcome them here and have them share with you their lessons learned from their program. Today, the presentation objectives include the sharing of results from the improvement in offers of preventative screening, as well as the EMR lessons learned as they relate to the National Change Management Framework. I'm going to tell you a little bit about Canada Health Infoway, a little bit about our Change Management Network and our framework, and then we'll go right to the presentation. Then we'll have time for questions and answers, and then a quick let you look at what's available in terms of resources to support change. Again, to ask questions, you can click the drop-down arrow and Q&A, and then you send. And that way it'll come to us, and we will see that. And when we have time for questions, I will read them out, and the panel will respond. Canada Health Infoway is an independent, not-for-profit corporation created in 2001. We have spent $2.1 billion in federal funding. We are accountable to 14 federal, provincial, and territorial governments. And that our mission is fostering and accelerating the development and adoption of electronic health information systems with compatible standards and communications technologies on a pan-Canadian basis with tangible benefits to Canadians. Infoway will build on existing initiatives and pursue collective relationships in pursuit of its mission. I've mentioned the Pan-Canadian Change Management Network, and it's one of our working groups called the Webinar Group that actually puts these presentations on. The mission of the Pan-Canadian Change Management Network is to collaborate and successfully communicate, educate, and promote the value of using change management methodologies, approaches, and tools at every stage of eHealth solution implementation and adoption. Our vision is to be recognized as a leading national network for change management approaches and resources that support the successful adoption of eHealth solutions. Our National Change Management Framework is based on information and perspectives garnered change management network that resulted in creation of the framework. And we believe that there are 6 core elements to change: governance and leadership, stakeholder engagement, workflow analysis and integration, communications, training and education, monitoring and evaluation. And today's presentation will talk about some of those key elements in the work that they have done over the last I think, 2 years. I'm going to now pass this over to Doug and his group, and they will tell you all about their TOPS program. Doug?
Well, thank you for the opportunity today to share our results. So toward optimized practice, as you heard, is in the business of helping physicians and the practices they work with implement evidence-based improvements. And in 2012, we were approached by Alberta Health as a result of a development at the Council of the Federation. All the premiers got together and decided that they wanted to endorse a particular guideline called C-Change, which is a guideline intended to affect and improve cardiovascular care of Canadians. It became a priority for Alberta's strategic clinical networks, but the challenge was this. C-Change involves 89 recommendations, all of which were aimed at primary care, and they covered a lot of care gaps in doing so. And as you may imagine, trying to implement 89 recommendations and targeting 89 different behaviors is extremely challenging. And the question that Alberta Health posed to us is, so what could we do of this work and what could we take to scale? And what we found was, when we based on our previous experience, is that there were 3 major premises that informed what part of this job we thought we could tackle and how we would go about it. And the first is this, that some of the care gaps that we encounter arise from missed opportunities for patient engagement, not physician execution. And this is really critical. There's a tendency to believe, especially for primary care, that some of these care gaps arrive out of failures of the physician to reliably provide certain care. And when we look at the data and when we look at our previous experience, that turns out not to be the case. What's happening is they're not necessarily seeing the patients for the right things that they could be dealt with, particularly in the area of screening and prevention. The second premise was that we could improve care delivery by coaching the clinic team. Once again, this is key in that what we found is that not all of this is physician work. If we want to change who the physician is seeing and improve the outcomes, we need to engage not just the physician, but the team around them. And the third element is that we could do this at scale by using our primary care organization partners, particularly in Alberta's primary care networks, and doing a train-the-trainer approach. Now, for those of you who may not be familiar, in Alberta, we're largely still fee-for-service, and our primary care network partners are primary care teams that add value to independent fee-for-service clinics by offering allied health care support and some organizational support. But they do that in the context of value add to more traditional fee-for-service. So why Alberta Screening and Prevention? Family physicians, I mentioned, do an outstanding job of screening individual patients when they present for screening. And we had done previous work on that in another project, and we found, just for example, that patients who present for screening get their blood pressure taken 97% of the time. But if you look at the larger group of patients attached to a particular physician, that number is only 69%. And it really comes down to that there's a lot of patients who simply do not self-present for screening. They may present for other conditions, but it never occurs to them to come in for screening. The majority of Alberta patients are attached to a physician, even when they're not coming in. So this represents the biggest single group of underscreened patients, is patients who are attached but not presenting for screening. And then evidence says that our most effective behavior change tool for those patients is to have an invite from their primary care provider or the team to complete the screening. And as a corollary, what was found here in Alberta is that opportunistic or outreach, opportunistic meaning catch the patient when they're presenting for something else, or outreach meaning calling patients who haven't showed up in a while, that those two things work and is time and cost effective. So ASAP opportunity arose is primarily focused on supporting the physicians and, in some cases, nurse practitioners and their team members to offer a screening prevention bundle to adult patients. And as I mentioned, we did this in collaboration with primary care organizations, including primary care networks, also FCCs and academic departments of medicine. The maneuvers we focused on were these 12. I won't go into detail. They're available on our website, but there was an evidence-based expert committee who assembled these 12. Now, not all of these 12 were on the C-Change guideline, but a really important consideration we've found is in implementing clinical change is that primary care doctors don't treat for disease, they treat patients. So in the context of screening, we really had to talk about what are all the things they need to screen for, not what are the disease states that they need to be paying attention to. So really a patient focus. So we offer a variety of training. We offer training to the PCNs to help them facilitate the implementation at their local levels. And in the context of this, we did a lot with electronic medical records. The feedback we always get on our projects is that EMRs are the key enablers, and without knowing how to do it in their EMR, they can't proceed. So with the help of the primary care organizations, we engaged physicians to participate and offered practice facilitation. And this diagram probably shows the degree of variety that we encounter. Sometimes we could work directly with clinics. Sometimes we work with the overall network, who in turn worked with clinics. And it really had to be adapted on a case-by-case basis to the local situation. So I'm just going to move ahead here on the ASAP intervention. There were several stages. The first stage was to really help the clinics to make sure that they understood, not just in the physician's mind, but actually in their electronic medical record, who their patient was, who their patients were in their panel. And that turned out to be a lot less mature than everybody had hoped, and took a lot more work to help clinics sort out. Once they began to have an idea who was on their panel, we helped them to begin improvement. So they would do a baseline chart review, and then they would implement improvements in one of those two categories, as I mentioned, either opportunistic screening or outreach to patients who hadn't presented. They would do this in a PDSA fashion, small test of change, standardized processes, and make improvements. And after approximately 4 months, then we supported them with a follow-up chart audit where they looked at how successful they were, and they got feedback from our database on how to proceed. And we continue to offer on an ongoing basis sustainable chart reviews and follow-up reviews. But the data we're going to be talking about today, that is very early. We don't have the sustainable part in place yet, but lots of follow-ups. The benefits for the panel for participating in the benefits for the clinic, in participating in ASAP was enhanced role for the teams. This is really important. The teams are really the drivers of this process. They were able to identify and use their panels not just for this but for other things. They developed screening processes that were customized to their clinic. They got an introduction to process improvement tools and methods like the PDSA, and then they enhanced their ability to use their clinic EMR.
So we wanted to share the lessons learned that we had around EMR use for the purpose of patient panel identification and preventative screening that took place in this initiative. And as the EMR lead for the initiative and the team at top, we had this opportunity to have this provincial lens of view across the province, patterns that we saw in EMR as a result of the improvement initiative. Just to give a background to participants, over 80% of primary care providers in Alberta are using an EMR. There are 3 EMRs that do dominate the space in Alberta, and they are owned by one vendor, and one of those EMRs is most prominent. There are another 3 that make up the rest of the minority, and after that, there are some smaller EMRs used across the province. What we did realize for the initiative is that we would have the capacity as a result of this landscape to assist improvement facilitators, PCNs, and clinics in their use of EMR. So what did we do to provide the support to clinics across the province? We did an environmental scan, and that allowed us to see what was happening across the province with current use. We've had EMR users that go way beyond 10 years in Alberta, so we had lots of experience across the province. We identified leading practices. We also took our time to identify resources that existed both within the EMR solutions themselves and outside those EMR solutions. There was also the ability to learn from the vendors, attend their meetings, and learn what was some of the beneficial things that clinics could be doing. As a result, we created documentation in the form of tip sheets that would support users in using their EMRs. Importantly in that, one of the tactics that we took was to recommend the use of existing information where it occurred. So where there was help files and videos, we were able to point users in that direction. We also created webinars where we had experienced users presenting their perspective of use and sharing it with others. We worked with vendors where possible, or vendors did create templates that were beneficial to participants. Attending user meetings and participating in vendor user meetings as presenters, facilitating the sharing of templates amongst users, and really creating that network that didn't exist amongst users because they were doing the same thing. There was also that ability to create some on-site and virtual support where we work directly with users in the clinic on their EMR. So let's look at the specific EMR activities that took place. So the first part was panel identification. And because we do not have formal rostering of patients in Alberta, we were supporting the practices in developing informal rostering. And that is what we call panel identification. And that's attaching the active patients to the provider in the EMR. That meant important use of the status function, validation, as well as the reporting fields in the EMR. And ultimately, the clinic should be able to produce a list of active patients attached to each provider for primary care services. Panel maintenance activities would involve identifying those processes in the clinic that would maintain accurate panel identification. And that would be an example, for example, producing a list of patients that hadn't been in the clinic for a great period of time, let's say over 3 or 4 years, validating that list, and then changing the status of patients that had not been in there for a period of time. Next, clinics would move on to what we call panel management, and that is processes in the EMR for proactive care, and in this case for Alberta Screening and Prevention, it was for preventative screening care of adults in the clinic. The EMR activities that were very important there included the recording of offers of screening, because that's what the measurement was about, hopefully in a standardized and structured format, and that would involve a template or stamp of some type in the EMR. Next, clinics were encouraged to adopt a clinical decision support tool. And 2 examples that were very important in the initiative were something like a population-wide reminder or rule that would tell a team member that a patient was overdue for preventative screening care. Another tool that became useful for the EMRs that had it was something called a flow sheet, where a flow sheet is a display of patient information over time, showing the documentation in one place for the patient. Finally, the clinic would also need to take advantage of the reporting features of the EMR and use that reporting for the purpose of improvement. I also wanted to share the context of the EMR in the other changes that were taking place in the clinic as a result in this initiative. Optimizing EMR was just one thing that contributed to the improvement going on. The clinics were also experiencing changes for the enhanced use of Teams, supported by an improvement facilitator that offered practice facilitation to the clinic. During this time, they were also using the model for improvement for process improvement, and it all related back to the EMR if the clinic was an EMR clinic, which most clinics were. In a nutshell, though, what was going on, the clinic was making a change from offering individual patient care to proactive population preventative screening care, and the EMR was a key enabler for that. So within that, there were some key lessons learned, and I'm relating these to structures within the Pan-Canadian Change Management Framework. So let's look, first of all, at leadership. Whereas leadership is very important in the change that was taking place at the clinic as a result of practice facilitation, when we look specifically at EMR, there should be some leadership specifically for EMR. There would have been a sponsor supporting that leadership, and there would have been, as well, a facilitator that would have supported those changes. There was also likely an EMR lead at the clinic, and that person would be accountable for the changes taking place in the EMR. As well, there would have been a panel manager in place, that person that supported the proactive care of the patients in the EMR. Somebody at the clinic within these leadership levels also needed to make those linkages for the clinic team on the standardization of the clinical processes, both in and outside the EMR, related to the clinical priorities that they had for preventative screening care. Within that as well, another important consideration was stakeholder engagement. And one of the key areas for engagement with stakeholders was in the area of clinical documentation. Ultimately, the goal is to have a degree of standardization that will enable the clinical decision support tool and reporting. But in approaching this, there needed to be a balance. And this is that balance between standardization of those using the EMR and the stakeholder needs. We know it's a big shift, for example, for team members, especially primary care providers, who would do the documentation, and they were familiar, let's say, with doing that completely in a note field and not using a standardized template. Well, in shifting from notes to a standardized template, that would have been a big change for them, and they would have needed to balance the need for standardization for the need of the provider to get through their day and document their encounters in a timely way. Importantly, though, again, as this is going on, teamwork is an important element to consider of who does that work and how their documentation takes place in the EMR. The next part has to do with workflow analysis and integration. So I've been repeatedly making that linkage between the charting that would take place and the data entry and the ability for the charting to influence a clinical decision support tool such as a reminder, and then the reporting that would come out of that. So when the clinic engages and starts using a clinical decision support tool such as a reminder or rule, a process needs to be in place to support that reminder. And in starting that, it's not an easy process for the first time a clinic does that. They get the reliable reminder acting, and then they need to have a reliable process put in place to act on that reminder. And in doing so, the clinics were encouraged to use the model for improvement to develop a reliable process. And in doing so, it's encouraged for them to start small in that process and grow. And that's when we look at incremental change and not step change. So when a clinic goes live, that's a big step change. But the incremental approach to using a rule of reminder is a good example of an incremental change. So for example, a screening change that would have occurred in the clinic was using a blood pressure reminder. Sometimes it's too big of a change to just turn on that rule or reminder for patients that are overdue for blood pressure screening. But if the clinic breaks it down into smaller increments and turns on that rule or reminder for, let's say, the population of one doctor, and instead of starting with all the patients in their population, they can break it down to a smaller group. For example, males between the age of 60 and 70 years old to start with. Once they have their reliable process in place and they're ready to expand it, you can configure the reminder in the clinic to include more patients until eventually you have all of the reminders working in the clinic. Another important thing, and this has been passed on from physicians with lots of experience in using reminders, is that if they are ignoring them in the clinic, and this happens where a clinic says, oh, we've had a reminder in place for a long time, but we don't really use them, is to turn it off, start small, and work forward incrementally. And then add screening maneuvers as it's appropriate for the clinical group, because everybody has their own pace of change that they can accommodate. Another big learning that I saw provincially was in the area of training and education. There was certainly an advantage within this project, and what I saw was two things. People were going in a common direction, and they were also learning as a group, or they were like a school of fish together. So there was very much an advantage in this initiative where there was a common goal, where many clinics were working on screening improvements at the same time across the province in the same EMR. And once you had users in the same EMR sharing tips and approaches, these were shared, we facilitated that across PCNs, across clinics, across peers and facilitators, as well as in collaboration with vendors. Another very useful activity pattern that I saw during the initiative was training, as well as learning at the clinic. And many clinics don't have a learning strategy, and this was an opportunity for them to think about a learning strategy at the clinic level. It was very frequent that I encountered users, and they may have been very experienced, but they had never even gone into their own health files, where there were useful documentation or videos that showed them how to do a process that was going to be very useful in the initiative. As well, this was a time to think about new staff training and the development of advanced users within the clinic that could become super users. Another interesting pattern that I saw in the area of training and education happened when we were doing some work at TOP and learning about Dan Pink's book, Drive. In his book, which I would recommend everybody to look up, or his very short YouTube video, it comes down to three activities that can lead to better performance and personal satisfaction amongst employees. And they're autonomy, mastery, and purpose. And what I saw when there were team members at the clinic that were able to master the EMR through a variety of processes, be that vendor training, shared learnings from other users, use of the tip sheets, help files, and documentation that we recommended, they were able to get much farther ahead with the EMR than they ever were in the past. With two other factors, one being autonomy, they were allowed to do their work, with the second factor being a strong purpose, and the purpose being preventative screening. These people put in huge discretionary effort that led to marked improvements in their organization. And these could have been an improvement facilitator, but they might have been another team member in the clinic as well. Another key element, as it relates to EMR and the improvement initiative, is measurement. And while we know that measurement is central for the model for improvement, EMR reports throughout the initiative were key as well. And clinic teams could monitor their own performance using reporting within the EMR. And when it comes to using reporting within the EMR for the purpose of measurement, and that would have been the use of the search or query functionality in the EMR or the practice management reporting, is if they adopted a hive mentality, there is an advantage. In which case, not one person within the organization held the knowledge and skill to be able to use the reporting functionality in the EMR, but it was a number of people. And in understanding the reporting functionality, they also made a greater degree the connection between data entry, the clinical decision support tools such as a reminder, and the reporting. And this became an advantage to the clinic as well. So while we know how the clinic is using the EMR, Doug and Margot are going to share some of the results of the initiative to date.
So I'll start us off here. We believe that we have 2,800 eligible providers who could theoretically have been reached by this initiative. But in practice, only about 2/3 of family physicians are really willing to prioritize screening for a whole variety of reasons related to what their patient population is and business model and that kind of thing. So we believe that we had a potential ultimate enrollment of about 2,000 participants. And that was where we set out to ultimately get to. Now, as of this reporting, so we had an artificial cutoff of December 5th, 2014. We were at 390 participants. So the data you will see is based on those first 390. We're currently at about 430 since in the 2 months since our cutoff. But of those providers, 387 were physicians, 3 NPs. Our dropout rate was only 6, which is pretty solid. That's just the number of physicians who moved during the course of the project so far. With a combined of about 350,000 adult Albertans within their footprint who could be affected. A little more intense rollout in rural than urban areas, which is the reverse of our population distribution here in Alberta. But our experience is that the rural physicians tend to be a little more nimble in their opportunities to change. And Margot?
Yeah, I just want to mention too, Doug mentioned that our cutoff was December 5th, and we did conduct an evaluation of the project in the fall, and so these results all reflect December 5th. The maneuver selection, as Doug mentioned earlier, we had a group of people, specialists and general practitioners, that came together to determine them, and with the result of having 12, the physicians actually had a choice of which maneuvers they could put into play, and so we had the anywhere from 5 to 12. It was an opt-out as opposed to an opt-in, and we had, in terms of 12, we had 61.3% that chose that and 85.4% that chose 9 or above. We were actually surprised to see, you can see the number who selected this of our 390 physicians. We had, with the tobacco, the exercise, and the alcohol, we were quite surprised to see the number that took on those because they would have been fairly low to start with because they're not traditionally part of primary care. They're taken care of by other, either public health or addictions and those kinds of things. So we were pleased to see that and showed that their commitment to ASAP and screening. Flu had the lowest selection rate, but most flu vaccinations in Alberta actually take place in the public health setting or in pharmacies, with the minority occurring within primary care practices. Go ahead. The measurement was completed through a chart review process so that we took a baseline measure of the offers of screening for each of the maneuvers that a physician had chosen, and then we did a follow-up. We originally looked at 4 months for this to occur from enrollment to follow-up, but just given the fact that most physicians needed to implement the panel processes, that we found that it took about 7.4 months on average. The baseline was done on the full panel, so they took a sample and the physicians could choose the number of charts that would be reviewed, anywhere from 10, 15, 20, or 30. And then the follow-up was completed as well. It was not done entirely on the full panel. If it was opportunistic screening, they would look at take a sample from all those that had come in the last 2 months, plus another part was done on the full panel. If it was outreach screening, then they would look at those that had come in the last 2 months, plus those that have been contacted for outreach screening. So it was a little bit different, and it was focused on quality improvement and not in research. And so it was a little bit different in terms of the protocols for that. Next, please. We're very pleased with the increase in screening rates. We had a 16% increase from 49% baseline, and this is aggregate from all 390 providers and aggregated for each of the maneuvers. They were averaged, and then that was aggregated. We had anticipated around 10%, so with the 16%, that was 1.5 times an increase, so we're pleased. Now, the increase could be partially attributed to improvement in documentation and improvement in use of the EMR rather than improvement in offers of screening. So the physicians might have been offering the screening already in the baseline samples, but they weren't being captured appropriately or within the EMR, or were in different places. So the chart reviewer wasn't actually able to determine that. So again, part of that increase could be attributable to the improvement in documentation, as well as improvement in offers of screening. The effectiveness across all 12 maneuvers is shown here. We did the baseline provider rate, follow-up rate, and then improvement. And this is for the match. There's 145 providers that actually had both the baseline and follow-up as of December 5th. And you can see that the improvement rates range from 6.8 to 25.2. 11 of the 12 maneuvers were actually statistically significant, with the cardiovascular risk almost there, and actually it's reached that status at this point. The cardiovascular maneuvers included blood pressure, plasma lipid, and diabetes, and they had the highest baseline rates, but still had significant increases, especially in blood pressure. Cancer screening included PAP, mammography, and colorectal cancer screening, and they had increases between 11 and 12%. Anecdotal evidence from physicians and clinic teams of how the improvement process was in the EMR has resulted in early detection and positive patient outcomes. And we have had some great stories of patients or of physicians discussing how early detection and treatment has improved patient outcomes. The lifestyle risk factors were ones that I mentioned before that physicians don't traditionally include within, and so they started out fairly low. We had some at 9.1. You can see the flu, or 26.6 with exercise. Yes, they increased dramatically. They capture the broadest range of patients without gender or age restrictions, and I should state that our age for screening was 18 to 79, and so that could attribute to some of that increase as well. And the one that didn't quite reach significant, although it is at this point, but still has a lower rate, is the cardiovascular risk. It started at 20.1%, went up to 26.9%. It's still 6.8% increase, but it's still at 26.9%. So this is an area that will need some more attention, and part of it is that this isn't something that the physicians can ask a nurse or MOA to do. It's something that they need to do themselves. It's a little more involved, and they need to have the risk calculator either on the EMR or preferably on the EMR, I guess, or on paper, so that they can pull all the information together and then have that conversation with physicians or with patients. It's not that they don't want to do it. I think it's just a question of how they might implement it during the regular visit. And so those are our results at this point, or some of our results, just to give you an idea of how the EMR has played a big role in our increase in screening rates, offers of screening rates.
Thanks, Margot. And we knew that for this Provincial Improvement Initiative that EMR was going to be a challenge for the practices in changing their EMR processes, but there were solutions that existed within the existing EMRs without development of the EMRs and their capacity, and we needed to find and share those solutions. We also know and continue to know that EMRs have significant untapped potential, and that we are not using what we currently have to its potential within the province. Participants are telling us as well that EMR is key, and because processes are all linked to processes within the EMR, they are drivers of the change. We also are seeing that participants are making that clinic connection to their data and thinking about it in a different way. As they're looking at their clinical improvement for preventative screening care of adults, they think about data entry, how it can impact their ability to offer screening to their patients in a reliable way, and it can also be used to inform their decisions on patient care. It's becoming an increased emphasis within the clinic. All right. Karen, do you have some questions for us?
I do. Well, first of all, thank you, Doug, Margot, and Barbara. This is very interesting stuff. Some things that jumped out to me was that Margot mentioned, that you initially thought that having the change would take a shorter period of time, but on average, it was 7.4 months to implement the change. That is, select your maneuvers and create the processes. So that's very interesting. I think a lot of people have challenges with EMR and think if they're going slow, that's not good. But obviously, and I like how you showed that leap to just little staggered steps, and that you take little steps at a time, so you're building on knowledge, functionality, expertise, going from success to success rather than jumping too high and not being able to be successful for a long period of time. So I found your information very, very interesting. I'm just letting people know that we are now opening up the Q&A panel. So if you have a question for the panelists, please do put them in the Q&A panel and I will read them out. In the interim, I have a question. First for Barbara. How should a doctor go about optimizing their EMR?
Thanks, Karen. I think importantly, you shouldn't think, a physician or a physician office shouldn't think about optimizing an EMR in isolation. Really, optimizing care is the objective and understanding the potential contribution that the EMR creates for the necessary interest of optimized use. But within that, some key points are to first identify a sponsor and or leaders for the EMR optimization in the clinic. And once they identify a clinical objective, they need to think about the clinical inputs for that objective. So thinking about the data inputs, whether they be documentation in the patient's chart and or lab feeds. Once they do that, they incrementally introduce a tool, such as a reminder or a rule, and measure their progress on both using the tool as well as their progress in the clinical care that they're wishing to achieve. And reporting is key for that, and understanding how to get reports out of your EMR. It does help to have a framework such as the model for improvement at the clinic, as well as what we've learned and the evidence shows that practice facilitation is a supporter for that. And at the same time, they can identify with other clinics that are undergoing the same or a similar change, that are using the same EMR, and they can share their lessons learned and their tips on using it with others. It's very helpful.
Great. Well, thank you, Barbara. That was very helpful. I have a question for you right now. What thoughts do you have for the inclusion of populations that may not have a regular family doctor, as in the case of many parts in the country?
So that's a great question, and we got that question a lot during the course of this project, because as we talked about, we were starting with the group of patients who were attached, as they represent the majority. But there are also parallel work going on here to try to attach patients who don't have a regular family physician to a clinic. For example, we're doing some work on that with a group of MS patients who don't have a regular family physician, and can we get them attached, and can we make sure thereby that they are able to take advantage of this kind of care. But it's I think a great example of there's no silver bullet here. You can't fix everything for everybody. You work on one population, but you do have to be aware that you need other strategies to help address other populations who can't take advantage of what you're offering.
Thanks, Doug. I have another question that just came in. Were the doctors getting engaged easily, or did you have to pitch to them what's in it for them? So obviously, this is it's a process that takes a little time. It requires them to do some focusing. Was it hard to get them involved?
That's a great question, and yes, it does take some time to pitch it to them and get them involved. One of the things we learned is we really needed that pitch to come from physician leads. That's where we needed the help of our community leaders to really go out and reach out to their peers and say, you know, this is a good project. We think you might be interested. One of the advantages, interestingly, that rural physicians tend to have over urban is that there were more natural channels for that conversation, which is why we saw the pitch happen a little bit faster in rural areas. Some of the major barriers, interestingly, I don't think my EMR can do this. So you have to kind of debunk that concern that in fact they do have the functionality in their EMR and it can be done. And the other big concern, of course, nobody would be surprised to hear is, oh my God, this is going to take so much work. It's going to, you know, I'm going to generate a lot more patients, and it's, you know, it's going to bog me down. We didn't present that result, but interestingly, we did do before and after studies of their how well they ran on time and what their access were, and ironically, those things actually improved slightly. So the challenge that this was going to create a bunch more work simply did not materialize.
And to add to what Doug said, something else about motivating the change, something that we've seen is where the practice facilitators and the primary care networks are sharing what's going on early on, as well as the early physicians. They're getting the others involved because they are seeing success. And whereas you see yourself catching something in preventing cancer care, those providers are talking about those patients that they are catching early on and preventing, I'd say, cancers from growing, and that is helping to spread the change.
Awesome. Obviously, leveraging peers, whether they're in a formed group as peer networks or just colleagues that have already experienced this and are real champions and mentors of others, has been really important in this initiative.
So there were both strategies. So yes, primary care networks have leadership groups that we approached, and we got their endorsement. There was a provincial level leadership group here called the Primary Care Alliance. We approached them. We got a letter to every doctor in the province. There was every primary care doctor in the province. And then we recruited and supported a group of physician leads to basically do roadshows, to go out to various communities and present on this at natural venues. So there was both an informal and a formal outreach mechanism to help enroll and engage physicians in this work.
That sounds like excellent stakeholder engagement. We have one more question. I'm not sure if you can answer this, maybe Barbara. How is TOP going about engaging the EMR vendors? Where are you at this point through your program?
Yes, I've been engaging with the vendors from the beginning. We first of all informed them about the provincial initiative because we didn't want them to hear about requests from their customers without knowing about the initiative and what was behind it. Just for information of participants on the line, we don't have a budget for paying EMR vendors, so there was no money to the vendors for anything that may have taken place as a result of the initiative. But one of the key principles behind the engagement was helping their customers optimize what they had. And if the clinics were effectively using their product, then they would be more satisfied with that product, more likely to continue using it in the long run, and see the benefits that it's had that maybe they didn't tap into in the past.
Great. Thank you very much. If you could turn that over to me or advance me, Barbara, I'll go through our final slide as you close our webinar. Again, to remind you about Infoway's vision, it's about helping Canadians through innovative digital health solutions. And we support in all kinds of ways at all different levels, at new practices, existing practices, clinicians in training, primary care, nurses, pharmacists, medical office assistants. We try and do everything we can to support this initiative, and that's why we have change management webinars, and we try to focus them on all the different stakeholders that are involved in this in healthcare, so that we can provide them with some good success stories and tips and tools. Next slide, please. Question and answer, we had that. Available, we have change management resources. We have an online toolkit repository, and we also have a LinkedIn page called the Pan-Canadian Change Management Network. It is a member only, so as long as you go in and request to join, and you're working in healthcare, you are readily approved, and there we have discussions, and we will have some more discussions with the top team over the next week on that page. So I invite you to come and join and have a look. And then just give you, let you know what's coming up on our next webinar. Webinar coming up next, March 26th, 1 to 2 p.m. Eastern Time. It's called Explore Links Between Physician EMR Use and Care Quality and Productivity. The National Physician Survey, released in December 2014, reveals physicians' adoption and use of electronic medical records increased 54% points to 77% between 2006 and 2014. In addition to sharing the results, the webinar will feature the experiences of the British Columbia program that worked with physicians to increase clinical value by advancing EMR maturity. So this is a great follow-up to our discussion, because TOP in Alberta is doing, we've heard us doing some very similar things, and now we'll hear a story from BC, as well as linking it to the results from the latest physician survey. So we do wish that you would go online to our website at Infoway and sign up for this webinar, as you did the one that you're participating in now. And we hope that you will listen, because it will be very interesting. Thank you. Next slide, please. Thank you very much. 2 minutes to the hour, top of the hour, so we'll be done a few minutes early. We appreciate all that listened and participated with questions. Again, we'll be going over to our LinkedIn page and adding some more questions of the top team, so we invite you to join us over there this next week. And again, thank you very much to Doug, Margot, and Barbara for an excellent presentation, great information, and continued success. I look forward to hearing more about TOP in another 2 years. Thank you very much.
Awesome.
Thank you.
Thank you.
Okay. Goodbye, everyone.
Thank you again for joining us today. This concludes today's web conference. You may now disconnect.